Welcome to our ONC Health IT Certification Program Developer Roundtable. My name is Tom Deneen with Kaufman & Associates and will be assisting with the logistical support for this Zoom session. Please note, the materials contained in this presentation are based on the provisions contained in the 45 CFR Parts 170 and 171. While every effort has been made to ensure the accuracy of this restatement of those provisions, this presentation is not a legal document. The official program requirements are contained in the relevant laws and regulations. Please note that our other federal and state and local laws may also apply. The communication is produced and disseminated by the U.S. taxpayer expense. You can ask questions by clicking the Q&A button, which is located towards the bottom part of your screen. Click on the Q&A bubble icon, and this will pull up the Q&A box, which will open to the right side of your Zoom interface. You may also use the raise hand function under reactions, and we will unmute your line to verbally ask questions during the session. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker if on camera as they present or share information. If you need technical assistance during the session, click on the chat bubble icon at the bottom of your screen, and this will pull up the chat box and open to the right side of your Zoom interface. Please type the issue into the chat box and one of our techs will respond to you. Finally, please be aware that today's session is being recorded. Closed captioning is available by clicking the CC icon at the bottom of your screen. I will now turn it over to Rob Anthony.
Thank you, everybody, for joining today. We have a few different items to walk through. Myself will be talking through the B10 EHI export. I'll be turning it over to our Deputy Jeff Smith to walk us through some of the Cures update and progress report. And then we will also get from Tony Myers, who is the branch chief in program administration, an update on the SVAP procedures and what 2023 is looking at like. Can we go to the next slide? So we'll do a little bit of a year in review with Jeff. We'll do a little bit about the coming B10 EHI export criteria deadline and what those requirements are, and then look at the standards version advancement process and where we are in that cycle with public comments open. Next slide. And I will turn it over to Jeff Smith, who is the Deputy Director with Certification and Testing.
All right, thanks, Rob. Good afternoon to those of you on the East Coast, and good morning still to everyone else. Can I go to the next slide, please? I'm going to provide a little bit of a year in review, as Rob said, highlighting what I think is really a watermark, high watermark moment for the program, and a real milestone, I think, for the industry. So much of this will probably be, somewhat review or somewhat obvious, but I think it's worth taking a moment as we wade into 2023 and some of the few remaining requirements that were established in the 2020 Cures final rule to honestly stand back and admire what it is we've accomplished in the last several years since that rule was finalized. I'm going to hit on a few of these points here. I think particularly of importance is the standardized FHIR APIs that were developed and implemented over the course of the last 2 years. I think it's important to note that these APIs will facilitate interoperability across certified health IT developers and clinical settings, really serving as a foundation for innovation and supporting the development of new and innovative software applications. And I think we at ONC, and I think we share the sentiments of industry, believe that these APIs will serve as a foundation for an entire ecosystem that will be underpinned by specific FHIR standards for the very first time. And we think that this will help ensure that healthcare providers, health insurers, public health agencies, ACOs, researchers, and patients have access to consistent data that ubiquitously across certified health IT. We also think that these APIs will help patients more easily connect to different sources of their own health data, enabling them to aggregate their information into a singular view or use different apps to understand their health in new ways. Next here is on the US CDI, and I think it should be well known that the US Core Data for Interoperability version 1 is now the law of the land. And for the first time, all health IT modules that are certified to kind of 6 specific certification criteria must support both the CCDA and FHIR-based representations of US CDI version 1 data elements. Since finalization of Cures in 2020, ONC has adopted, of course, the US CDI version 2 and version 3, which expand the number of data elements in version 1. I think version 1 had 53 data elements, version 2 has somewhere in the neighborhood of 70, and then version 3 has close to 94. And if you look over time, this represents roughly a 33% expansion year over year of data elements across versions. And I think it's important to note that this has been a highly telegraphed process, something that we've worked very closely with numerous interested parties to identify data elements for incorporation in versions 2 and versions 3. And I'll just highlight that version 4 draft is currently available for public comment. So that's something that if you haven't been involved in the US CDI process heretofore, you should take a look at the draft V4 and let us know what you think about specific data elements that are being considered for incorporation. I think we can go ahead and go to the next slide because I'll talk to some of these other issues next. So this gives you a sense of where we landed after the deadline for Cures update. And I think this is, and I'll say this a few times, I think this is a reflection of the will and the interest of industry to meet the deadlines on time. You can see here across various data elements that require the US CDI, we're well above 90%, above 95% across all these, almost all these cases, and even closer to 100 than we are 95% in most of these. And I think this just reflects a tremendous amount of effort and work by certified health IT developers and our team here on the certification program. Next slide. Okay, and this is a look at G10 specifically. I think it's worth noting here. I think we used to call this the hockey stick when we were talking about adoption of electronic health records way back when. We talked about the hockey stick effect of getting providers to adopt electronic health records across stage 1 and stage 2 of meaningful use, and we saw this dramatic uptick once stage 1 incentive dollars started rolling out the door, and here you can see a dramatic uptick when negative incentives started knocking on the door of developers who were not yet certified to the G10 standardized API for patient and population services requirement. And again, I think this is a typical, I think, representation of what we see across the industry when we look at deadlines and when we see developers go to their ACBs. But again, I think that the highlight here is not so much that developers waited until, or had until just a few days or weeks remaining in the year to get certified. But I think the top line here is that nearly 95% of all developers who were kind of scheduled or had G8 certified technology made that jump to G10. And I think that's a really important and laudable aspect of what we experienced in the Cures update. So if we could go ahead and go to the next slide. Okay, a couple other pieces. One that was completely new and one that was partially new and also with real-world testing. I think we were delighted when we had 100% compliance rate with real-world for the first round of real-world testing plan submissions. And I think we thought that boded well for attestations, and we were right. There were 2 attestation periods in 2022, and we had a 100% compliance rate. And I think it's really just important to note what a feat that is, both for attestations, which at one level is a fairly straightforward checking of boxes, but at another level is a fairly complicated exercise that we know many in the developer community had to go through in terms of coordinating with their legal departments and trying to understand the requirements of exactly what they were checking boxes to. But I think on the real world testing side, that was even more of an impressive compliance rate that we had for plan submissions at the end of 2021. And so across 2022, we were somewhat excited to see what the real world testing plan result submission would look like. And I'm happy to state that as of today, over 98% of developers have successfully submitted results indicating how their real world testing went across the course of 2022. Real world testing is one of those areas that, again, we give developers maximum flexibility to determine metrics that they think are important to demonstrate the real world interoperability of their certified health IT. And I think there's just bound to be loads of really interesting and really important information across these real world testing plans. And we're eager to get into some of the real world testing results to really kind of understand how industry views interoperability testing, real world testing for interoperability, that is. So I will just highlight that we've got a special Chapel button. If you go to the Chapel, you can search for real world testing plans. We've got a predefined search that can help you find your own real world testing plan as well as those of other developers. Next slide, please. Okay, so SVAP, the standards version advancement process. Now this is another really kind of important, I would say, policy mechanism that was finalized as part of the CURE's final rule in 2020. And this is another component of the program that, quite honestly, we weren't entirely sure how it was going to be received or how it was going to be used. And now that we've gone through a couple of cycles of SVAP, I think it's important to note some of the stats that we've been tracking, and we can and hopefully what it portends for interoperability across the industry. So as of today, there's been just over 110 SVAP updates across almost 50 Chapel listings. And I think it's important to note that because the SVAP allows developers to use newer versions, we I think in no small way think about the newer versions as being better versions, as being versions of standards that either have more functionality or capability or address deficiencies at a minimum in previous versions. And so I think we're really happy to see that several modules have used new versions of the US Core implementation guide. There have been a few modules that have used new versions of both the Smart Application Launch Framework as well as Bulk Data Access Implementation Guide version 2. And then, of course, there's a number of modules that have decided to use US CDI version 2 instead of US CDI version 1 to be certified to specific criteria. And, again, I think it was an open question as to whether or not developers would avail themselves of using newer versions when they weren't required to use new versions, because that's usually been the case. And I think we've taken a lot of time and instituted a lot of internal processes so that ONC isn't the rate limiting factor for interoperability or for the use of newer versions of standards. We have to do a lot of regulatory jujitsu on our end in order to specify standards just by order of the Administrative Procedures Act. And, for years, ONC was cast as being this impediment because developers would work on standards, and standards would get balloted, and then standards would be available for use, that, oh, it wasn't in ONC's regulatory program, so developers couldn't use these newer standards. And SVAP removes that barrier to some degree anyway. And so, I think we're optimistic that, again, over time, once we have newer versions of standards that are developed, developers will be able to use newer versions of standards that hopefully improve the functionality and interoperability of their products. We've made SVAP summary information available via the chapel. We've included the hyperlink there, and I know several of you have got questions about slides, and they will of course be made available to those that registered to attend. But if you'd like to take a look at the data that underlies this slide, feel free to go to the chapel and check that out. All right, next slide. Okay, just a quick plug here for Lantern and a quick highlight on one of the requirements for those of you that have certified API technology, and that is around endpoints. So in the CURE's final rule, we included requirements that endpoints for service-based URLs would be made available, and this would be true for customers that use kind of cloud-based technology, as well as customers that have on-premises certified API technology. And around the same time as the final rule, we worked with MITRE to establish Lantern, which is an open source tool that provides some transparency and provides some data and information on Fire-based endpoints rather. I took a screenshot from the dashboard that's publicly available just this morning, and you can see that there are currently 15,000 or so endpoints that are available through Lantern. And I think a couple things. We know that the requirement for developers is to provide updated technology to their customers, but that customers are customers have their own ability to deploy, adopt the technology and deploy the technology on their own timeline. Of course, we do rely on CMS requirements, which will incentivize hospitals and physicians to adopt and use certified API technology by the end of this year. So we know that there's an unknown number of hospitals and eligible clinicians out there who have developers that have certified API technology available, but not yet deployed. And so we know that that's leading to an undercount at this point. But the other facet of this that we know in conversations with our partners at MITRE is that endpoints are not being made available by developers in a consistent form and manner. And we've included some direction in a certification companion guide for the API condition that really encourages developers to use the Fire endpoint resource and organization resource that would include organization name, location, and NPI if possible. But I think generally speaking, we're also cognizant and aware of patient access brands and endpoints, which is an emerging kind of effort to try and coalesce industry around standardized ways of making endpoints available with brand information. And so, I think insofar as you're a developer that has endpoints for your customers, we would encourage you to look at what others in the industry are doing to standardize around a format, because that's going to be a really important component of this, so that patients can easily access their information, which is really what this requirement is all about. It's meant to facilitate access for individuals who have a specific provider and want to connect to their API. So at any rate, we've got a little bit of work to do here. If you've got additional thoughts or interests on Lantern, happy to put you in touch with the right folks. Okay, next slide, please. Okay, this I think is one of my last slides, and it's basically just a commercial for a host of resources that we've developed that are related to the Cures update. I think we've got something like 24 resources out there that include fact sheets and resource guides and other materials. And I would just encourage you to take a look at those if you've got questions about anything that we talked about. Rob's going to go into more detail on the EHI export, but we did just recently produce a fact sheet there. And we have constantly been updating the real-world testing resource guide and API resource guide, as we find additional points of clarification or as we come across questions that we think are helpful to have wider discussions about. Next slide. Okay. Last but not least, I think we wanted to take this time to just say congratulations to everyone who made the Cures deadline and are now working with customers to get technology implemented and deployed. As I mentioned, we think this is a genuine milestone for the program and for the entire health IT industry. Standards-based APIs will further adoption of FHIR, and this will set the course for increasing interoperability across clinical use cases and improve patient access. We think this is going to be really helpful for not just clinical settings, but also for public health and also for research and also for quality reporting. And we're working with federal partners as we speak to try and figure out how can we take advantage of this growing body of consistent standardized data elements in healthcare, and how can we do it in a way that doesn't burden providers or patients. And then we also think that, again, when looking at SVAP and the kind of routine cycles that we have established, we're hoping that this allows industry to move at pace with technology development, with standards development, and removes ONC and our rulemaking as a rate limiting factor for advancing functionality and standards adoption. And we also think that SVAP and the US CDI and the Interoperability Standards Advisory and the body of work that we engage in on that side of things will help us identify areas where further standards development is needed, and then we can redirect resources towards those areas that are needing further development. So with that, I think we can go to the next slide, and I'll hand things back over to Rob.
Thanks, Jeff. As we have gone through what we have done and what we are doing, now we can turn our eyes to what work we have before us. The B10 electronic health information, the EHI export criterion, is the final criterion that is required under the Cures update. I'm Rob Anthony. I'm the director of the Certification and Testing Division. I'm going to walk through some of the basics about EHI and also maybe address a couple of questions that we've been seeing coming up on JIRA through our customer support about specifics related to EHI. Next slide. Okay, so the B10 EHI export criterion does replace the previous B6 data export criterion. It enables specifically 2 use cases. Providers can export all of the EHI that is stored in a certified health IT product or a product of which the certified health IT module is a part, either for a single patient or for an entire patient population. If the product designation is a little bit confusing to you, I'm going to cover that shortly. The other scenario this covers is individual patient access to electronic health information. And we will cover the differences between those, and those are requirements. As with the previous Cures update requirements, you saw this with G10. I just want to remind everybody that the requirement is not just that the product be certified, or the module be certified to B10 by December 31st, but it also needs to be certified and made available to end users by December 31st of this year. So not just certified, but actually the functionality available to users. Doesn't mean that users need to be using it by that date. It just means that it needs to be available to them if they want to. Next slide. Who is required to be certified to B10? The requirement for B10, just so everybody is clear, happens under the assurances condition of certification, actually under the maintenance of certification, and it requires that certified health IT that electronically stores EHI has to be certified to the Cures update. We get questions sometimes about, well, what if that certified health IT is part of a larger product that stores electronic health information? Yes, that absolutely means that your certified health IT module needs to be certified to it, and that the EHI that is stored as part of the larger product does need to be exportable as well under EHI. If you have certified health IT that uses relied upon software in some way, that also needs to be exportable under the B10 requirement. So I know different folks may put together their base EHR package using some relied upon software, and that also needs to be factored into the export. Similarly, if you have certified health IT modules that leverage some sort of third-party storage, whether that is a separate server or a separate product, it is important to understand that the requirement here is if the product of which the module is a part, so not just the module itself, but the product that you sell or you make available to the user of which that module is a part, causes electronic health information to be stored, it doesn't matter where it is stored. It still needs to be exportable from that place. You are going to want to submit to your ONC ACB a description of how this is working, and they may have some additional documentation that they will require for folks certifying to B10. But you should also reach out to your ACB, not only to see what it would be if you have to certify to B10, but also what they may require if you feel that B10 does not apply to you. I think many of the certification bodies are requiring an attestation statement and description about why you think that B10 does not specifically apply to you. A question that has come up recently for a number of folks is whether a developer that has a module that is part of a product storing EHI can simply direct customers to a third-party solution and not have to certify to B10 themselves. In other words, can they completely rely on a different third-party solution, not make it part of their product, and not have to do that certification to B10? And the answer to that is no. You absolutely have to certify to B10 if the product of which your module is a part stores EHI. There is nothing that prevents you from utilizing a third-party solution as relied upon software packaged with your particular product, but you would still have to certify to B10 in yourself as a developer for that product. So pretty basic rule. If your product of which your module is a part stores or causes to be stored electronic health information, then you have to also certify to B10 and provide that functionality to the end users. Next slide. We also get this question a lot: what is electronic health information? And I'm not going to delve deeply into this. There is a link, you will see the slides later, that you can take a look at to see more about this. But electronic health information we define in regulation as the same HIPAA data set that is referred to in federal regulations. They call it electronic protected health information to the extent that it's included in what gets called a HIPAA designated record set. We do, similar with the HIPAA designated record set, call out the exclusion of psychotherapy notes or any information that is compiled in a reasonable anticipation of legal proceedings. But otherwise, it is that entire data set. We get a lot of questions about, does this piece of data need to be included in the EHI export? And I'm going to run through, I actually went through our customer service JIRA questions before this to take a look at some of the things that came out. We get asked, what if the EHR is integrated with another product? Yeah, that information has to be exported if that module is part of another product. We talked about that. What about if the certified product is not storing the information and it's stored somewhere else? The requirement here does not limit it to the certified module, and it also does not limit it to information produced by the certified module. It is the entire product of which the module is a part. So all of that would be exportable or required to be exported. We often get questions about individual configuration of things. I can tell you that ONC is not able to issue individual judgments about different configurations, but again, would urge everybody to follow that basic rule of, if the module is part of a product, then all of that EHI is must be subject to it. We've been asked about some specific data points, things. If there are multiple values of a particular piece of data stored, so multiple addresses, for example, does everything need to be exported or just the active record? We don't make that distinction within regulation. So it is everything that would fall under that definition of EHI. Similarly, we've been asked about, manually entered data or customers who create a custom data field on their side. Again, if it is part of that EHI definition, then yes, that would be. It doesn't matter if it's part of the regular product, it does need to be exportable. You're seeing a trend here about what is exportable. It is everything that falls under that EHI definition. That is ultimately what we go back to. We've been asked about file attachments. That is also, if it's EHI, under this definition, it gets exported. So basically, I would say if you have questions, does X need to be included in the EHI export? You want to basically ask yourself those two questions. Is it stored by the product of which the certified module is a part? And would it qualify under that EHI definition? If the answer to both of those questions is yes, then yes, it does need to be included in the EHI export. Next slide. EHI export file format requirements. This is largely very flexible. It is left very much to each developer to figure out the best format that they want to use to support their product. What we are requiring is some transparency around a file format or data dictionary that would allow people to be able to parse the information that is exported. So if you look at the regulation language, you will see that all of those exports have to be accompanied by a export file explanation that allows people to parse that file format information without any additional steps or preconditions. You have to keep that documentation up to date. There is a space in the chapel for every product to carry a hyperlink to that documentation. You want that file format to describe the structure and syntax of how the EHI is exported, not necessarily the electronic health information itself. And the goal here is to get to this thing that is in regulation, that the export file has to be in an electronic and in a computable format. It can't be considered computable if there isn't some sort of guide as to how you compute it. And again, if you go back to those use cases that need to be supported, the use cases to be supported are entire exports of patient information or individual exports of patient information so that they can be consumed by another system. It can't be consumed by another system unless they have this file format, structure, and syntax which describes it. One question that we get asked is whether the export itself can be a PDF. And I know there has been some confusion about this, and some folks say yes, and some folks say no. So I'm going to give you an answer here, but first I'm going to pause to take a brief drink, a dramatic pause here. Okay, so I'm going to go back to this language. The export file needs to be in an electronic and in a computable format. There is nothing in regulation that specifically prescribes or prevents the use of a PDF to meet the certification requirements of B10. But the requirement of computable format still has to be met by the developer. And I would actually encourage people, we do some similar language about this in information blocking for an FAQ when asked about providing things through a PDF. You want to keep in mind that a PDF that would be used for this would need to be in an interpretable, machine readable output. And that's possible for some PDFs, but there are other PDFs, especially some PDFs that include images and other things. They may not be interpretable and machine readable. So one way that a PDF can be machine readable is if it is structured so that the data can be consumed by another software program, and that would meet that computable format. So some PDFs are just static. They're not readable in that way. That type of a PDF would not be considered computable, but certainly a structured PDF and an accompanying data dictionary or export file format explanation that indicates how it could be consumed could be used to meet the B10 requirements. Next slide. There are two different use cases here. One is for single patient. One is for the entire patient population export. They have slightly different requirements. The single patient EHI export has to be able to support exporting all of that information for any single patient at any time the user chooses without developer assistance. However, I want to be clear that this doesn't require direct to patient functionality. This can be done on the provider or user side. But if I were to sort of shorthand this, and don't take this literally, but if I were to sort of like shorthand this, I would say this is the push button type of use case. There needs to be a way on the user end to be able to say, give me this for a single patient, and it will export that information both in a timely fashion. It will have all of the EHI for that single patient. It will be in the electronic and computable formats. It will give you the publicly accessible hyperlink that will lead you to information about how to use that format. And part of that functionality is that you do need to be able to limit the users who can perform that. It is up to the developer how that is structured, but think of this use case broadly as the push button automatic type of use case for a single patient. Next slide. Then there is the second use case, which is the entire patient population EHI export. It also has to include all of the EHI, but for the entire patient population, also has to be in an electronic and computable format. It also has to include that publicly accessible hyperlink of the exports format. So it's the data dictionary that describes how you were able to consume this information. But, and we talk about this in the preamble of the Cures Act final rule for those who care to take a look at it, this is something that could require additional action or support on the part of the health IT developer. Exporting an entire patient population and all electronic health information can be a complex procedure. We recognize that. and we recognize that it may not be as easy as a push button. So it can be something that can require additional steps. It is not, however, and we have gotten this question before, it is not, however, something that can be executed solely outside of the software itself. So part of the requirements is to meet the B10 requirements and be certified to that. Your module itself must be certified, which means the request for a patient EHI export needs to be at least initiated by that module. So that functionality is there, but it could require some additional support on the part of the developer, and we leave that broadly to developers to decide. Next slide. Jeff mentioned the EHI export fact sheet that we have available. There's a link to that here. You will see that in the final slides when they're made available. I would also encourage people to take a look at the CCG, the Certification Companion Guide. We keep that pretty up to date. So if we issue new guidance on B10 in response to any questions that we get, then we do keep that CCG updated, and you'll be able to see that there. I'm going to turn briefly to some of the questions that we have seen in the chat. I think I've answered some of these. Is a certified product is integrated with a non-certified product? Does that data need to be included in the EHI export? Yes, if that module, that certified module, is part of the non-certified product, then yes. It is, however, possible, and many developers I know do this, where they provide a certified module and they also provide a one or more non-certified products to the end user. If those products, if the module isn't part of a product, then no, it is not subject to that. However, if the module is part of the product, then anything that is within that product would have to be. We have a question about what is the responsibility of a data archive with non-certified legacy data if it does not allow patient access and only feeds data to the EHR. It goes back to the exact same question. If the electronic health information data if it is part of a product of which the module is part, and that product causes that data to be stored, then it would be subject. However, there is not a requirement to export data that is not caused to be stored by the product. So if the feed is one way, then it may not be subject to it. However, if the module causes that information to be stored, then, or if the product of which the module is a part causes to be stored, then yes, it would be. We've seen some developers who are certifying to B10 stating that they would use a CCDA as their export format. There's nothing that prescribes that. Again, electronic and computable. As long as that CCDA meets those requirements and there is a hyperlink that is provided to file information, file format information that allows another system to be able to consume that data, then it could certainly be used to meet that. Is blue button text format considered computable? If it is, I'm not completely familiar with all of the ins and outs of blue button's text format, but it again comes down to, is it consumable? So if you have a data dictionary, would you be able to consume that particular information? If it is well defined, like a PDF where certain areas go in certain places and that can be automated to consume, then yes, it well could be. Somebody asked about if we could confirm that fees cannot be charged for B10 export when developer assistance is needed. That is absolutely true. B10 is a required certification functionality. You cannot charge under conditions of certification additional fees for what is required functionality under the program. So you must support the automatic, what I have called that one button or push button approach to the single patient. You can to do an entire patient population export, provide as a developer additional end assistance to achieve that export, but you cannot charge for it. It is part of the required B10 functionality of the product. A question about making, or a comment about making the export format consistent with supported standards. We did get some of those comments in the ONC Act or ONC Cures Act final rule. At the end of the day, we decided that not only would we use all EHI that was exportable, but because there is not a particular standard, we would give wide flexibility to developers in how they decided to structure these formats. And provide those EHI exports. So part of the reason that you are able to do this in any way that you would choose to is because it allows you to export all of the information. Can I better define psychotherapy notes and how they are to be separated from other clinical information? I cannot. That is not the purview of ONC regulatorily. It is a HIPAA definition, so I would encourage people to take a look at that EPHI definition in the earlier reference. That indicates what is psychotherapy notes that can be excluded. There is not a specific electronic requirement from the ONC about how they are separated from other clinical information, but there is some separation of what must be provided according to HIPAA compliance. So I would refer people to that. I'm not able to answer how a CCDA would meet the EPHI definition. It is a question of how that particular developer chooses to use that format. As long as a CCDA could be populated in such a way to export all of the stored by EHI, it could be conceivably used in that way. But as far as the exact way that it would be structured, it's going to be up to the developer. At the end of the day, again, it needs to be all of the EHI that is applicable under that HIPAA definition, and it needs to be both electronic and computable. For the patient population expert, in terms of the developer providing action or support, but the provider needs to initiate the request. Yes, that is correct. No, the provider's request could happen through email or support if it is initiated through the certified application. So you can't simply say, hey, if you want to make a patient export, or a full patient population export, call this number. There does need to be a way to initiate that action through the B10. We certify the functionality of the product to provide this, and we do say within regulation that you can provide additional support beyond just what is in the functionality of the criterion, but it does need to be initiable or startable through the actual certified application. I'm gonna switch over. I see some things happened through chat rather than Q&A. The explanation about PDFs was not clear enough. What about information that is an image that can be exported as a PDF? That's actually one of the things that we cover in our IB question, and that is exactly the issue that may be a problem for a PDF. If a PDF can't support all of the EHI that is stored by the product of which the module is part, then that's not going to be a viable alternative. It could be part of a viable alternative, but it's not going to be the full viable alternative. And an image is an excellent example of that. If you can't put that image into a PDF, then of course you're not going to be able to use that PDF to support that. So there are plenty of systems that don't do that, but you want to think about what is actually supported by that PDF and whether that PDF can be structured in such a way that it can be consumable. If there is information that is not an image format and it doesn't have a standardized structure, I will say that there's a fair amount of information that I think is would be covered under the EHI definition that doesn't necessarily have a standardized structure at this point in time. However, that is what the file export data dictionary would be for, right? So that you could say, this information is in this area and it's done in this format so that it can be consumed on the other end. However, if you have information that you cannot put into some sort of a standardized format in the PDF so that it can be computable, then of course a PDF would not be able to support that, and they would have to look at some other way to looking for it. I did answer the question about charging for assistance for B10. You can't charge for additional assistance. You need to be able to provide a way to do that entire patient download. But if a user needs additional storage space, then I think that probably doesn't fall under the system requirements unless, of course, you're providing the storage space as part of the certified module itself. But as far as the actual provision of the data, that has to be done at no extra cost. If the EHR system is hosted in the cloud and it is it is a situation in which I think that would fall in if you're providing that storage space as part of the product, then no, you won't be able to charge extra for it. Now, you may have something in your contract with users where they have to take that patient download from the cloud in a particular amount of time. But the point here is to not be able to introduce any type of additional fees that would interfere with the full exercise of the certification criterion itself. So I think broadly, that's the way to perhaps think about any type of fees that are involved here. Happy to pause for a moment if anybody has other questions. I see again a comment that initiating export via the certified health IT module, it is not just the single patient export capability, it is both use cases. The single patient export capability has to be initiated on the user side and completely initiated on the user side. The all patient export has to be initiated on the user side, but can require additional development. Again, our regulatory or statutory purview here on the ONC certification side is the certification of technology. So we do need to see that functionality that can be supported through the actual E10 criterion, the certified module itself. It doesn't have to be completely executed there, but it does need to be initiable there. All right, well, I see no additional questions. Thank you very much. I will go to the next slide, and I will hand this to Tony Myers.
Thanks, Rob. Good afternoon, everyone. I'm Tony Myers. I'm the Program Administration Branch Chief here in the Certification and Testing Division. Jeff reviewed some of the advanced standards through the SVAP process and the adoption of those standards in the certification program. I'm going to talk a little bit more about how SVAP works, review the annual SVAP cycle, and then take a look at the 2023 proposed standards. So next slide, please. So just a brief overview, SVAP is a voluntary process that allows certified health IT developers to advance to newer approved standards other than those adopted in regulation. So every year there's a cycle
that we go through. It goes through a public comment. I'll touch on that in a few slides later. And why is it important? Well, first of all, it provides the flexibility for those newer standards to be adopted without going through rulemaking. Rulemaking does take a while, and so this was a way to advance standards and keep up with industry. And through the SFAP process, the national coordinator approves those standards on an annual basis. It also makes it predictable because it's an annual process that we go through. And importantly, it supports interoperability in the real world and gained it in real world implementation use. And so one note is that SFAP was established by ONC as part of the real world testing condition of maintenance and certification requirement in the 21st Century Cures Act. And I'm going to talk a little bit more about those criteria under the real world testing condition and maintenance and certification. Next slide. So SFAP and certification, it's limited to standards adopted and certification criteria in the real world testing condition, which I'm going to go over in the next slide. It also it makes available flexibility not only at the time of initial certification, but in the maintenance of the certification or the certification of a module. And it addresses those standards updates in the real world testing plans and results. We've just gone through a full cycle of real world testing plan and result submission. So I'm sure most of you out there are familiar with that process. If you have any questions about the actual SFAP process, there is a link here, and the slides will be made available in the coming days where you can get more information on the process. Next slide. So here are the applicable real world testing certification criteria. I'm not going to read them all. I'm just going to note that they're categorized under care coordination, clinical quality measures, patient engagement, electronic exchange, public health, and APIs or application programming interfaces. And all these are available on our website. Each one of these links that you'll receive in the slides goes to the certification companion guide, where you can get more information, clarifications, and supporting documentation for each of those criteria. Next slide. So how to use SFAP. Certified health IT developers can leverage SFAP, as I said, either at the initial certification or to maintain the certification of a particular module. If a certified health IT developer does use the flexibility to update to a newer version, they are required to do a couple things. First of all, for existing certifications, advance notice needs to be given to the customers, the affected customers of that use that module, as well as the developer's authorized certification body, or ACB. And then in that notification, developers just need to let them know of the intent to update to the more standard or the advanced version, how it will affect interoperability for each one of the modules, and whether they intend to continue to support certificates for the existing health IT module version. And in addition, developers need to successfully demonstrate conformance with approved or more recent versions of standards and maintain the updated certified health IT modules in full compliance with all the certification program requirements, which are in the real world testing plans, addressed, in the real world testing plans and results that are submitted. Next slide. So the SFAP cycle, it's an annual cycle. The standards division and certification division work together and considering new standards based on what's going on in industry. That list is then compiled. It goes for public comment. It is now currently under public comment. There'll be a link on the next slide or two where you can access the proposed 2023 standards and comment. Once we get those comments back, we review the comments, and then we determine which we are going to publish as part of the SFAP cycle that year. Next slide. So here's the link to the annual process, so where you can make comments. The comment period opened February 1st of this year. It will close on May 22nd. And then we will announce the new standards in June of 2023. And 60 days later, in the month of August, those new standards will come into effect in the certification program. Next slide, please. Just a note about the public comment period. This is a collaborative process. We encourage you to make comments on the standards. We want to hear from industry. It's a very collaborative process, and it really does play a crucial role in selecting the final SFAP standards, so it can reflect the current industry trends. So yeah, so that link, it will be provided, and that link will be provided in the slides, and so we encourage you all to do that. Next slide. And then, so just a note about the previously approved standards. You know, if an adopted standard is approved during the SFAP cycle, it remains available until the newer SFAP version is available. And if a newer version is approved, the previous SFAP version will be replaced and no longer for use in the certification program. So certified health IT developers don't need to keep advancing to newer versions once they've used SFAP. And no new certifications can be made to the replaced SFAP version once the newer version goes into effect in the program. And any certifications to the replaced SFAP version will still be valid. Here's a link to the complete list of the standards. Next slide. Okay, so this is the proposed standards for 2023. I'm not going to read them all, but you'll see on the website, there's the regulatory standard. We've gone through 2 cycles of SFAP, so it will show you what standards have been adopted previously and what we are proposing for adoption in this cycle, as well as the regulatory text citations. Next slide. Like I said, the comment period's open, closes May 22nd. There's the link to where you can make your comments. And next slide, I think that might be it. Oh, yeah, and here are the SFAP resources. Again, you'll have access to these. They're on our website under program resources. With a lot of good information out there about SFAP if you plan to use it. And next slide, please. So thank you. We thank everyone for attending. We hope you found this useful. And like I said, the slides and recording will be available in the coming days. Thanks, everyone.
I was going to type this into the Q&A. If folks have additional Q&A that you want to send, please feel free to while I'm answering this. Somebody asked about the SFAP, if a newer SFAP version is approved, you know, and the previously approved SFAP will be replaced and no longer able for use. What does that look like operationally? Operationally, once it becomes effective, which is 60 days after we finalize and announce it, US CDI version 3 will be the only version that is available for new certifications or new version upgrades. If you are already on US CDI version 2, you are not required to jump to the newest version. So there isn't a specific deadline. So if you're on V2 already, and you want to go to the latest and greatest on V3, it does not need to be completed by that effective date. And in fact, the effective date is the soonest you could do it. It could be completed at any point after that. It's just that no one who is, for example, on US CDI V1, once that effective date hits, V2 won't be available for anyone else. It is absolutely conceivable, by the way, that I'm just going to use this as an example, not as a recommendation, because I'd love everybody to be on the latest and greatest of US CDI. But if you updated to V2 and you decided to not upgrade to V3, there's nothing that prevents you from doing that. It'll still show on Chapel that you were on the US CDI version 2. You would still show as being SVAP'd, but you don't have to do any particular update. It's not required to go to the next version. It just won't be available for anybody to go to the previous version. All right, I think we're a little past. Thank you, everybody, for attendance and for your time and attention. Look forward to seeing you all next time.